Hey, y'all.
You know, just listening to the great Steve Perry, of course, my favorite. Everybody knows that. Bumping us in, Rhino. I still have fun going out there and watching the reaction videos from the young folks. And, like, they'll crank that stuff like that up. Like, who is this guy? Never heard that. Before auto-tune, as you and I like to talk about. It's our pleasure to welcome now Leah Smith, General Counsel and Vice President for Policy and Advocacy for the Mississippi Hospital Association. Leah, good to see you. Thanks for coming in.
I'm so glad to be here. I always love coming to talk to you.
Yeah, awesome. Appreciate it. So let's kick it off by talking about Medicare, which is not as straightforward and easy to understand as many believe it is. It is a tangled web. It wasn't supposed to be that way, but with the advent of Medicare Advantage and Medicare supplemental policies, it's not like, and of course we got Part D that came into effect many years ago. It's the prescription drug coverage.
That's right.
You got these Part A, B, C, D. It's complicated, and folks that aren't insurance experts, they need some help, and you guys are trying to educate people.
That's right. That's right. We've got a public information campaign going that's really aimed at patients and what patients need. We also have concerns from a hospital perspective, but, you know, Medicare is a complicated program. We have about 640,000 Mississippians that are on Medicare. 57% of those are on traditional Medicare, which is the federal government-run program, and about 43% are on Medicare Advantage, which is a little lower than nationwide, which is at about 50%, which is interesting. I actually didn't know that before I studied up for today.
I didn't know that. Advantage, of course, considered Part C,
correct.
Of Medicare, and explain that to the folks. Basically, it's a private policy that has a bunch of stuff added to traditional Medicare.
That's right.
And you deal with the private carrier. Explain.
So we've got 4 parts to Medicare. Part A is really inpatient hospitalizations, skilled nursing, and some home health. Part B is outpatient and your doctor's visits, those sorts of things. Part C is your private plans, which usually combine Parts A and B and maybe add a service or like vision or dental that is not covered by traditional Medicare, which many people don't know that. Medicare, traditional Medicare covers medically necessary services. It does not cover routine dental, routine vision, which I consider to be very important in my life.
Sure.
It doesn't cover hearing. It doesn't cover long-term care. So it doesn't cover certain services that sometimes Medicare Advantage will cover, although there are potential downsides. And then Part D, as you said, covers drug coverage.
Yeah. And originally, as I recall, it was just Part B, I believe, was hospitalization, right?
That's
Did I get it backwards? Is it A and B? One is normal clinical, sort of outpatient primary care.
B is your outpatient, and A is your inpatient.
A is an inpatient.
That's correct. And you know, it's a common misconception. We were talking about this off air, but a lot of people think you pay nothing for Medicare, and that is not true.
One of the parts, the A, right?
So Part A, some people do not pay a premium, but they have a deductible. Medicare is an income-driven plan, and so if you are a high income earner, you're going to pay a lot more, and it's a mandatory transition. So when you turn 65 or you leave employment and lose your employer coverage, you have to transition to Medicare.
Right.
And if you don't, there are penalties.
Yeah.
And they're lifelong.
Like catch-up penalties.
And they're intense. I mean, they're like 10% of premium payments for every year you missed for your entire life.
Yeah.
So you have to watch out. When you start to turn 63, 64, you need to start looking out for when you need to enroll. And I think people don't know that. And they don't know what it covers, and they don't know what it doesn't. And they don't know that if you enroll, for example, in traditional Medicare, you might need to get a supplemental policy called Medigap that will help you with your co-pays, some of your deductibles, so it's not so expensive. And then you can add on to those with vision or dental or whatever you might need.
Yeah. So the Hospital Association's position on this, and I know you don't want to advise people on you should buy this policy versus that policy and this coverage, and I get that. But a person is approaching retirement, right? And they are looking at enrolling in Medicare. should they talk to like local professionals to help guide them through that process?
Absolutely. And one of the best things about Mississippi, and I was talking to a colleague about this yesterday who ran a local hospital field down in Southwest Mississippi. One of the best things is that we can go to church and run into one of our providers. So it's great. I mean, you have access to people who really do want to help you. You don't have to call a big insurance company that might be out of state and ask them for information. You can literally talk to your neighbors and your friends, and your local hospital is going to know almost everyone in town. So the most important thing is to talk to your provider about what is covered. So oftentimes, even though a Medicare Advantage plan might have bundled coverage that seems easier, it might have a lower premium, so your upfront costs are lower. Sometimes your out-of-pocket costs are going to be higher. Your provider networks are going to be slimmer. Yeah. So someone that you're used to seeing, you may not be able to see anymore because they might be out of network. They oftentimes have stringent prior authorization requirements. And even though we have a prior authorization law here in Mississippi that is pretty robust, federal preemption, sometimes those plans get around those prior authorization requirements that we have in the state. So you want to watch out for that. And separately, just while we're on Medicare Advantage, there is some devaluation for our critical access hospitals, payments to those hospitals under Medicare Advantage.
Okay.
So those hospitals are 25 or less inpatient beds. They are cost reimbursed, so they are made whole. So even if Medicare is giving them a per diem throughout the year, when their cost reports come in, they'll true up those payments.
Gotcha.
That does not happen with Medicare Advantage. So sometimes our critical access hospitals are shorted, which is a problem because they're caring for aging populations.
Which typically require more medical services, and that's more cost.
That's right. That's exactly right. And so what we tell people is when you get your statement back every year and it tells you how your plan is changing, you need to take a look at that. So don't ignore that. Make sure you call your provider and talk to them about that. Make sure you consider your budget and what you can afford on the front end and on the back end. That's really important. So just doing your research and not simply looking at advertisements.
Yeah.
I think that's something that I'm dealing with my parents, is making sure they're not seeing something on TV or getting a phone call and maybe becoming confused about that coverage. I mean, I would probably get confused and need some help looking at that. And so it's certainly something I'm talking to my parents about.
I think the latest research I did, United Healthcare, Humana seem to be the largest providers of Medicare Advantage program.
I was shocked to learn that it had really the market had consolidated
a bunch.
It's like 47% of the market is Humana and United.
Yeah, UHC.
And that's part of the problem with the networks.
Yeah.
One of the things we have advocated for, and AHA, the American Hospital Association, has advocated for, is just looking at those networks and expanding them through federal law, making sure that Medicare Advantage programs are being audited properly, making sure we're gathering the same kind of data from those programs that we are from traditional Medicare, and better aligning those prior authorization requirements.
Yeah.
Because as you know, prior authorization is problematic. If you aren't allowed to receive the care that you need when you need it, that can really be damaging to your health. And
the good physicians, as you know, will spend a lot of time working that on behalf of their patients get that prior authorization. So because they know the time is of the essence to get them the treatment they need.
And that's a big problem with plans in general is the regulatory burdens, the administrative burdens. If physicians are spending all that time trying to work around those requirements, they're not spending time with you.
Now, I would assume that all your members, except Medicare, as far as hospitals are concerned, right?
That's right.
And maybe you've got some specialty hospitals or boutique-type hospitals that perhaps don't, I guess. I don't know if we have any in Mississippi, though, but you see them in the some of the larger metro areas.
Yeah, I would say that most of our members are going to accept Medicare. Most of our payers across our members are government sources.
Yeah.
So it's either going to be Medicare or Medicaid.
Yeah.
If you're a children's hospital, or something like that, where you're treating a subsect of the population that really doesn't have a Medicare plan, that might be different. But no, most of our members are reliant on Medicare.
So what was the figure? Medicare enrollees in Mississippi?
Medicare enrollees is at about 640,000.
I'm shocked at that.
It's huge.
I haven't looked at that. Now, I know it's 45, 50 million nationwide, I believe, on Medicare.
It's huge, and it's growing. I mean, demographics are shifting, and we are becoming a more aged population.
Yeah. That's incredible. All right, if you can hang around, we're going to keep talking.
Absolutely.
We got
good.
Leah Smith here with the Mississippi Hospital Association. We're coming to studio. Leah Smith, General Counsel, VP for Policy and Advocacy, Mississippi Hospital Association, is our guest. All right, so I think we covered the Medicare gambit. I think the main thing is when you get to that point, get some help, right? There are plenty of folks that can help you.
And I've got some resources that I can share. Medicare.gov is a good resource.
Yeah.
In the state, we've got the State Health Insurance Assistance Program. It's short name SHIP. It's run by the Mississippi Department of Human Services, and it's mostly volunteers, but you can call 1-844-822-4622, and that's 8 to 5, and they can help you navigate plans. On the MHA website, it's www.mhanet.org. You navigate to resources and then navigate to the last tab, which is Medicare, and there is actually a checklist that you can use. So when you are going through this enrollment period, which, by the way, started October 15th, and runs through December 1st, December 7th.
Yeah.
December 1st.
Yeah. Gotcha.
Am I right about that?
I think that's right.
I think that's right.
Yeah.
December 7th. I'm sorry.
Okay.
There's a different enrollment period for the ACA Marketplace. So just through December 7th, you can enroll in your Medicare, and we've got a checklist on our website that you can run through with your provider, that you can look at whatever you need to look at to make good decisions.
Right around the corner.
Yep.
And, of course, the other thing that's around the corner, you just alluded to it, is open enrollment in the ACA marketplaces.
That's right.
That's coming up November 1st.
That's right, and that runs through January 15th.
Oh, man. So the concern, of course, that we want to dig into is that the Biden administration passed in the American Rescue Plan enhancements, increased the subsidies in the structure of the subsidies. Premium tax credits, as they are known, were temporary, extended those in the Inflation Reduction Act, scheduled to expire at the end of this year. That's at the heart of this government shutdown. And if those aren't extended, and really, I think we're at a point, Leah, probably that even if they had a breakthrough in the next few days, I'm not sure the industry, right, could inform people, okay, everything's back on the way it was. I'm thinking people on November 1st are going to get notifications of precipitous rises in their premiums.
So they're already receiving those notices, and they've already submitted their rates, and it looks like across the nation they're requesting 18%, but I think here in Mississippi it's between 20 and 40%.
One of the most severe.
I mean, it's going to be very high and really unsustainable. And part of the reason for that is if the subsidies are not extended, then there will be less people, presumably, that are getting coverage. Probably healthier people are going to come off of it. Because I know if I were 24, 25, or 26 and I was healthy and I thought I don't really need this, I probably wouldn't get it, right? So they're going to come off. So the risk pool is going to be higher. And so those insurance companies are trying to account for their profit margin and looking at the risk pool and saying this is going to be riskier and we're going to have to increase costs. And they're also looking, I think, at other things like drug costs and chronic disease rates and utilization. Utilization is up post-pandemic, and while that's a really good thing, we want people to go to the doctor. We had a decrease for a while, and that doesn't cost as much. And now people are using their health insurance. So
and also a decrease during the pandemic period of the various tests and screening procedures.
That's right.
And now that's starting to manifest where illnesses are being discovered at a later date than they would have if folks have been screened, and that costs more money to deal with. That's
right. I mean, I think there are so many residual implications of the pandemic, and I was thinking about talking about this on the way over here. It's been 5 years, which is shocking.
I know.
And I almost felt silly bringing up the pandemic today, right? Like,
but we're still...
Post-pandemic utilization is up, but it's true.
Lingering effects.
I mean, people didn't want to go into the hospitals. They didn't want to see their doctors. They wanted to stay at home where it was safe. And they were worried about coming back for a long time. And many things were not caught during that time. So we're kind of playing catch up, and we're going to be doing that for a long time.
Well, the other thing that happened, and get your take on this, because you work with the people that were most affected by this, is just the medical professionals, and so many who had all sorts of opportunities to leave and be part of these traveling teams, and unbelievable compensation for that. Many, after the pandemic, said, you know what, I'm burnt out, I'm going to go do something else, and that's created shortages, right? We have lots of beds in hospitals in Mississippi that can't be used because they're not, as they describe them, as staffed, right? We don't have the medical professionals to...
That's true. I mean, things are definitely much better than they were during the pandemic and right after. But the economy around healthcare, the healthcare workspace, it's just completely different. And we're trying to make changes related to that. For example, introducing virtual nursing programs so that our nurses feel less burned out and have more time and are shifting responsibilities. But man, people are still tired from what was going on during the pandemic, and we have not seen some areas recover. I mean, some healthcare areas are still very short. And we're working on that in Mississippi. We've got some programs that we're working on. But yes, I think health professional shortages are definitely accounting for increases in premiums for the EPTC and the marketplace plans, and also for private plans. Private plans are going up.
Well, the good news is, if you're considering a career in healthcare, you can get pretty good compensation just because of the old dynamics of demand and supply.
That's right. And you can go wherever you want.
Yeah, that's true.
Which I think there's such freedom in that. We want them to stay in Mississippi, and we're working on that every day. But even within Mississippi, you can go wherever you want and get a job.
All right, so we've got the ACA enhanced subsidies scheduled to expire, and if they do, Kaiser Family Foundation estimates about 70,000 of the 340,000 who are enrolled in the exchanges would, as you say, drop their coverage. The fear is many of those would be the low-cost, healthier folks, younger folks, and that would probably... So I've seen a report, Leah, that says that the increase in premiums is mostly due to those dynamics as opposed to the subsidies, right?
I've heard that too.
Yeah. Okay.
I've seen that too. I mean, they're just accounting for their risk pool, right? And I think, at the individual level, the impact is so big. I found this example that I thought was really good, because sometimes it's hard to imagine, okay, what's the federal poverty level and how does that really impact someone? But for a 27-year-old who's making $35,000 a year, which is actually 224% of the federal poverty level,
right in the middle,
it's still not a lot of money.
Right.
With the subsidies, they would pay about $1,000 a year, and without, they're going to pay about $2,600, and that's for like a silver plan, so a medium plan.
Road.
That's right. And so, I mean, we're talking about huge increases. That's an 153% increase. And for a young person or a person who's working construction or whatever, really, that's not very far off from a teacher. That's a lot of money. And they're going to be on the state health plan, but even private plans are going up. I saw increases of 6% this year, which is the most that it's been in 15 years. So health insurance is very expensive.
It is, and I know I point this out all the time. A lot of people point to the health insurance companies as, well, they're just making more money and gouging us and all that kind of stuff. But when you look at their financial statements, they're not terribly profitable relative to other industries. And I'm not defending insurance companies here. I'm just sharing financial facts. But the other thing is, we have what's called the medical loss ratio. So by law, which was part of the ACA when it passed, they have to pay out 80% of what they collect in premiums has to be paid out in claims, and if they don't, they got to rebate folks.
That's right. Yeah, I mean, it's not all on insurance companies. There are other factors too, like drug costs. I mean, I was looking at the impact of GLP-1s. Weight loss drugs. And while those have a really great impact in the long haul, they're very expensive.
In the short term, still got to pay for it. And it's causing insurance premiums to rise. So we have to balance what happens on the back end with patients, which will probably be positive, on the front end with the cost of that drug. And it's just increasing. They're increasing costs. What's on your radar with respect to the Hospital Association for the upcoming legislative session? What are you guys thinking about?
Well, we've got so many things that are in flux right now because of OB3, the big, beautiful bill, HR1 that passed. I know we've talked about that. Lots of changes on the horizon to our state-directed payment program, which is the program that allows hospitals to really cover up uncompensated care by taxing themselves and pulling down Medicaid money from the federal government. So, we're kind of just in wait-and-see mode.
Okay.
And we just want to kind of hold the line while we see what happens with the subsidies and with MHAP, and hope there are no more hits. Because it's been a little bit of a rough year for hospitals. I
get it. I see the same thing. Many are underwater from a cash flow perspective across the country.
We're okay right now in Mississippi.
Okay.
But, there's trouble on the horizon, and we want to prepare for that. We want to be conservative and smart and prepare now.
100%. Leah Smith, General Counsel and VP for Policy and Advocacy at the Mississippi Hospital Association. Appreciate you coming on,
Thank
Leah.
you. I appreciate you.
Yep. We're coming right back with half an hour of